Hello guys, welcome back. This is Dr. Ranjith here again. So here we are with one more episode of Pathology Nuggets, case series discussion for postgraduates. And I've been doing the last three Pathology Nuggets. I've been splitting the discussion what we had on bone and soft tissue lesion and giving it as an tiny bits and pieces of information. Right? So here in today's Pathology Nuggets, we're going to see about three unique lesions in the bone and all of them with the same history, clinical history. A 12-year-old person with a tibial lesion, all of them the same history. Radiology will definitely help you in arriving at diagnosis. Apart from that, what I'm going to look in the microscopy will definitely clinch me. There are definitely certain clues in the bone and soft tissue lesion. We're going to have a look at that. Fine. If you're a postgraduate and if you're listening to this video, do share this video to your fellow postgraduates. And as you can see there are lots of special classes which is going on the Unacademy app for postgraduates. We have started hematopathology a couple of days back. We have done with the basic in appearance of a bone marrow, how it looks and how to pick up them, right? So the link for downloading the Unacademy app will be down in the video description. You can download the app and you can use PathoCups to unlock all these classes. All these classes which helps for your pathology postgraduates will be free of cost and just a way to democratize education, and we learn pathology together, fine. You can see them anywhere like it's mentioned here. You can download the PDF, the images will be with you. The cases, the real life case images will be with you, and you can ask me the interact with us. If you are able to attend it live, that'll be very good for you. It's a learning point. We can sort out all your doubts in the class. If I know, I'll definitely help you with that. Fine. Okay. So without any delay, we'll go to the first case. As I said, case 1. I'm going to have the same history. There's no history, change in history at all. It's a 12-year-old with a tibial lesion. That's it. A 12-year-old with a tibial lesion. What I'm going to look at the tibial lesion is what we're going to see in this pathology nugget. Fine. I'll show you the image. I'm not going to give you any radiological findings for this, but definitely when you're going to report any bone soft tissue lesion, I want you to first look at the radiology. With that only you're going to come to a conclusion, right? So there's an image. We have 4 images here. There's a low power image. I'm sure many of you would have jumped to the diagnosis here, right? And it's a very classical finding, though. I want you to describe the lesion, then you'll go to the diagnosis. If I have to describe this low power image, I'll describe that it's a lesion composed of both bone and admixed your fibroblastic areas, might be, though I have to look in the higher power what they are made of. The trabeculae here, which are not straight, right, which are kind of curvy linear. I'm sure you must have definitely guessed where I'm going to. Look at this. If you look at this, it's really looks like a Chinese letter, right? It really looks like a Chinese letter. A curvy linear C-shaped, S-shaped trabeculae. In this power, I cannot talk about the pleomorphism, but I do have spaces in between them. Mostly looks like a fibroblastic area, right? Let's go to a higher power. The same image, what you're going to see in a higher power, definitely is in curvilinear trabeculae, right? I do have fibroblastic area, like we guessed. There's thin spindle of fibroblastic area. It is not any pleomorphism is not seen here. There's no giants, not much of giant cells. I don't see ATP, I don't see mitosis in this power at least, right? And this is a perfectly superb curvilinear trabeculae which looks like a Chinese letter. Chinese letter pattern, curvilinear trabeculae and intermixed fibrous tissue. My diagnosis is going to be fibrous dysplasia. It's very classical to got fibrous dysplasia, right? One problem with fibrous dysplasia, if you look at these trabeculae, is there an osteoblastic rimming? Are you able to see the osteoblastic rimming? Yes or no? Or do you want a higher power for that? Okay, we'll go for a higher power. Again, one more image. Are you seeing any osteoblastic rimming here? Is there osteoblast here? Actually, there's no, right? Whatever cells you are seeing here, the tiny elongated ones, those are not osteoblasts. Those are fibroblast which came close to the trabeculae, becoming more concentrated and looking better. That's all. All these are not osteoblasts. The condensed cell and nothing, the fibroblast which is getting condensed very close to the trabeculae, even here. To confirm our finding, we'll go to a higher power as well. Look at this. Do you see an osteoblast? Definitely no. Look at these cells. Look at these cells carefully. They are elongated ones. They are elongated spindle shaped cells. Actually, they are nothing but the fibroblast which is there in between the trabeculae, which is getting concentrated when it comes close to my trabeculae. I don't see an osteoblast. Whenever in a biopsy, you don't see an osteoblast, one of the thought process comes to me is a neoplastic osteoid. I do think of an osteosarcoma, right? I do think of an osteosarcoma whenever I don't see an osteoblast. The problem with fibrous dysplasia might be there, especially in a true cut biopsy, a J needle biopsy. See, because when you have an excision, you'll have the perfect architecture, C-shaped, S-shaped, everything. When I have a J needle biopsy, let's say the biopsy itself is only this much. and I have, that's all. The C goes outside it. I have few fragments in between a fibroblastic foci. That time might be difficult for me to pick up on a needle biopsy. That time, yes, radiology is going to be of utmost importance. You should remember that, you should know that fibrous dysplasia will never have an osteoblastic rimming. That's how it is. It's dysplastic. It's not normal, right? So it's a very easy spotter. Developmental lesion will happen definitely before puberty, most of the time. It's first or second decade of life. And the S-shaped trabeculae and the intermittent fibroblastic foci, which is completely normal, no atopia at all, right? So when I go to this is what your WHO talks about fibrous dysplasia. Principally bland fibroblastic cell. It should be bland. If it is abnormal, I'm going to think of something else. An osseous component is curvilinear, irregular, oven. It might not be lamellar. Majority of the area is oven only. And osteoblastic rimming, like we saw, will not be present in case of fibrous dysplasia. Sometimes what happens is, instead of having a curvilinear trabeculae, I can have some circular areas. They are like blotches. We call them cementoid bodies. You look at this, you can have round things like this. These are called as cementoid bodies. Again, when you look at a cementoid bodies, it looks like a regenerative tissue, right? Or it looks like a calcification, that's all. Look, yeah, calcification, nothing but a regenerative tissue looks like that, right? So don't mistake this also for something else. Again, this is not neoplastic bone formation. This is possible to be seen in fibrous dysplasia. It's possible in many other lesions as well. It is cementoid bodies, which shows a regenerating bone marrow tissue. It can also be, you can also see the same finding in a callus tissue as well, right? The first lesion was fibrous dysplasia. Why I was so much insisting on fibrous dysplasia, though being it a benign lesion, is I have a very close differential diagnosis, which might also look the same, especially the osteoblastic rimming. My doubt is how I am going to differentiate that, right? Same as case 1b, I will put it, same 12-year-old lesion, tibial lesion. I'll show you the image. Does it look the same? Thin, curvilinear trabeculae with in between, at least the low power in between, it looks like a very bland spindle shaped cell. Yes, same curvilinear trabeculae, bland spindle shaped cell, right? One characteristic finding here, which is not seen in fibrous dysplasia, is when you look at the trabeculae, we'll look at the finding soon. Here, see, here's the trabeculae, here is the trabeculae, here is the trabeculae, here is the trabeculae. Can I say almost every trabeculae here, whatever I'm seeing is more or less parallel to each other, at least most of them, they kind of parallel to each other, right? That's a very, very unique finding. Fibrous dysplasia might not have a parallel trabeculae because they are turned, they are curvilinear, right? They cannot be parallel because it's like a Chinese letter, right? It's going to be like this. They'll not be parallel with each other. That's how it is, right? They are very architecturally distorted. They'll be curvilinear, C-shaped, S-shaped. Here also I'm having C and S-shape, but predominant of them, if you look, they are parallelly arranged. So when you see a lesion with thin trabeculae, predominantly of open bone, we have parallel to each other, I want you to keep one more differential diagnosis along with fibrous dysplasia. We'll just have a look at them. Fine. We'll go to higher power and see if there is anything abnormal. Again, my stroma, I don't have nothing much to be worried about. There's not much of pleomorphism, at least in this image, right? Just go and have a quick look at one more image. Look at this. What are these? What are these? What are these structures? They are my cementoid bodies, right? As I said that cementoid bodies is not diagnostic of fibrous dysplasia. I can see them in many places. But what is most surprising for me is this cell. This cell is not looking good, right? It's looking a bit hyperchromatic. It's it's out of the ordinary. At least I don't see this much amount of hyperchromasia in normal fibrous dysplasia. We saw the normal fibrous dysplasia is very, very bland. It should be bland. This is at least not bland. So these are my two clues you have to search for. You have to investigate one diagnosis. When you have little bit amount of pleomorphism in the stromal tissue, think of something else. When you have the trabeculae, which is parallel to each other, think of other one. Here, my radiology plays a very, very, very important role. You have to sit in a tumor board meeting. Hopefully, it's an MSK radiologist. The radiologist should be able to differentiate fibrous dysplasia and its very, very close differential diagnosis, your parosteal osteosarcoma. This radiology will give a very big role for me. And yes, microscopy, I can easily confirm these two are my points, right? One of the closest differential diagnosis of fibrous dysplasia is parosteal osteosarcoma, right? Have a look at this. Again, this is from WHO. It's a low-grade lesion, first of all. That's why I have to search for pleomorphism. Sometimes you may not be lucky to pick up pleomorphism, especially as I said on a J needle biopsy, it becomes very, very difficult. I will go back and have a look at fibrous dysplasia. You take a tiny core or a J needle biopsy of a fibrous dysplasia, bland spindle shaped cells, little bit of trabeculae. I am not seeing the S-shaped at all. Little bit of trabeculae here and there. No osteoblastic remain. Will this also look the same? Yes, because a parallel arrangement, I cannot see that. I cannot appreciate it in a true cut or a J needle biopsy, right? Again, dysplasia, pleomorphism might not be present throughout the lesion. It might be minimal focally. If the biopsy misses that, it will almost look the same, right? So I'm having a bone forming lesion with fibrous. Keep these two as possibilities. You have to sit with the MSK radiologist because both the osteosarcoma as well as fibrous dysplasia age group also can be the same. So search for any pleomorphism there or not. If it's there, go ahead and do a marker. If it's not there, but still, if the radiologist suspects an osteosarcoma, again, please go ahead and do the markers. That's very, very important. The imaging should be given a little bit higher role than compared to your other organ systems when you do a bone and soft tissue radiology biopsy, fine. It's well-formed trabeculae with intervening fascicle shaped cells. Most of them, they will be minimal atypia. One clue, even which can pick up in a J needle biopsies, is an hypocellular lesion. If you remember it, you can go back a little bit. Go to the high power image of fibrous dysplasia and compare with that with a high power image of your parosteal osteosarcoma. Definitely the amounts of cellularity in a parosteal osteosarcoma is very less compared to a fibrous dysplasia. One clue for me to suspect microscopy wise. Very minimal atypia, very low mitotic activity, and it might be focal. So I might miss it on an initial biopsy. Excision is going to be very, very easy for us to pick it up, fine. And at the periphery of the tumor, the spindle shaped component can show invasion of the adjacent skeletal muscle. This again is useful in an excision. In a true cut biopsy or J needle biopsy, I might not get the adjacent tissue at all. So it might be difficult for me to pick them up, fine. This is one more clue on an excision. It will mostly in a parallel fashion and they don't show osteoblastic rimming. Osteoblastic rimming will not help me to differentiate a fibrous dysplasia and a parosteal osteosarcoma. So I need a very high tremendous amount of suspicion. You have to know there's a very close mimic. Don't just look at your multiple thin trabeculae and jump to a diagnosis of fibrous dysplasia. Without imaging, do not report any bone or soft tissue lesion. That should be the dictum. You have to look at the biopsy first without imaging obviously. So I'll tell you how to look at any bone and soft tissue lesion. First put the slide just as the age and the location enough. Put the slide, have a differential diagnosis, that's all. 12-year-old, I can have many differential diagnoses of having tiny bony trabeculae like that. Open bone, it could be simple callus. It could be Myositis ossificans. It could be Parosteal, it could be fibrous dysplasia, it could be ossifying fibroma. I have my differential diagnosis. We have read about non-ossifying fibroma. You know how to differentiate them. The cellularity, the story form pattern, all of them. So I can come to a very too close differential diagnosis. Maybe in this case, I have a parosteal osteosarcoma and a fibrous dysplasia. Then look at the imaging, what they're saying. They also concur with fibrous dysplasia, go and give ahead. If there's a slight differential diagnosis, it's fibrous dysplasia or a parosteal osteosarcoma. If the radiologist thinks of that, you have to do a marker. The marker which WHO prefers is MDM2. You can do a SAT-B2 or an MDM2. Actually, this is an image of an MDM2. This is MDM2. MDM2 is a nuclear positivity, right? This I want to talk about this for any pathology postgraduate who's going to look at IHC. Generally, when you look at an IHC, whatever be it, especially the commonest IHC done is ERPR and Nertinu, right? So it's an ERPR and Nertinu. What we generally do is we report it on a low power. I look at an ERPR and Nertinu, I report it on a low power. That's all, right? So, but when you're reporting a soft tissue lesion, I want you to take time and go to a higher power. The primary reason behind this is soft tissue. They are all spindle-shaped cells. Especially these are fibroblastic foci, right? They're extremely thin, and they are nucleus. So if you look at this, it's just a line. It's just a line, right? Very, very thin positivity. So on a low power, with especially a very hypocellular area, that's what can be seen in parosteal osteosarcoma. I might miss them. Only for fibroblastic lesion, please go to at least 20x to report an IHC. Don't report on a 4x like any other thing. You have to go and look. You also have to look where it is positive. Again, it's a very thin cell. Nuclear positivity can be overlooked, can be missed. MDM2 is nuclear positive, and here almost every stromal is positive for MDM2. I'm going to call it an parosteal osteosarcoma. Again, even in this, you can appreciate that the trabeculae are parallel to each other, right? that will be there in parosteal osteosarcoma. Two different diagnoses. One is a dysplastic lesion, one is a malignant lesion. Though it's a low-grade malignancy, it's still a malignancy. Obviously, the management is going to differ. I want you to keep in mind, not everything which is thin trabecular is fibrous dysplasia. I do have a subtle differential diagnosis of parosteal osteosarcoma as well. Right? The next one, what you're going to discuss here is the same, actually about tibial lesion. So I'm not giving you the exact side. We'll go and have a look at the biopsy. I want you to comment on the biopsy. Then we'll go to the differential diagnosis. It's a very, very simple one. It might come as a spotter in your final year exam. If it comes as a spotter, it might help you. Fine. Just have a look at this image. It's a biopsy image. What you can see here is I can kind of divide this lesion into two groups. If I can draw a line here, I'll call this 1, I'll call this 2. Fine. If you look at 1 and 2, there is definitely a drastic difference. Whatever you're seeing in 1, what I'm seeing is only soft tissue, maybe fibroblastic. It does look like fibroblast. I need to go to higher power to confirm it's fibroblast or not. And when you look at the second area, I do see lots of osteoblast, the bone formation there, right? So I see an area completely full of fibroblasts, and I also see an area which is osteoblast, right? It's kind of adjacent to each other. That's my first finding when I'm going to look at this image. Let's go to a higher power image. We look at the osteoblastic area first, and then look at a fibroblastic area. At this image, it could be two lesions, it could be the same lesion, it could be deep differentiation. Who knows? I'm just putting all the things in perspective now. Fine. Second thing, we look at this image. Definitely is the bony area. If you look at that, though it's in low power, I'm sure you can appreciate the giant cells. I do have lots of giant cells. There's definitely oven bone formation. It's not lamellar. Lamellar will have lines. There's definitely some regenerative bone formation. Do you see an osteoblastic rimming? Yes, I do see an osteoblastic rimming, right? Especially here, you can easily see the prominent osteoblast, maybe if you're osteoclast as well, the osteoclast as well, right? So it's an oven bone formation with an osteoblastic rimming and osteoclast also present. So at least I would put my osteosarcoma down the road. I'm not going to think of an osteosarcoma here. So I'm having a bone lesion with in between fibroblastic lesion with few of the giant cells. Let's look at one more image. The first area which we marked, the fibroblastic area, right? This is the fibroblastic area. If you look at this fibroblastic area, there are two things which I want you to appreciate in this fibroblastic area. One, the nature of fibroblast. Whenever you look at any fibroblast, like in the fibrous dysplasia, what we saw was a very bland, very thin fibroblast. That's the same thing what we saw in your parosteal osteosarcoma as well. Hypocellular, but a very thin, spindled out, very narrow fibroblast, right? But when you look at this, first possibility for me, can I say the nucleus is a bit plump here? It's obviously plump, right? I do have a very plump nuclei here. Not only that, can I say that cytoplasm is a bit pinker and elongated? It is pink and elongated, especially here. Look at this cell. I do a very long pink cytoplasm. With a nucleus, right? So I do have a nucleus which is a bit plumper than usual. I'm having a long pink cytoplasm. When you have this appearance, I want you to go for a higher power, though I don't have a higher power image. These thin pink cytoplasm might have few striations. Might have, not always, right? So these are structures which I'm going to call them. This is how a myofibroblast or an rhabdomyofibroblast, both of them looks. That's why I want you to know. If it's having striations, I'm going to think of a rhabdomyodifferentiation. If it's not having striations, just a pink area, I might think of a myofibroblast, a smooth muscle differentiation. So this, I'm going to call it a myofibroblast because this didn't have striations. It's just smooth muscle, which is obviously will be pink in color, which is extending. So I'm seeing a myofibroblastic lesion. It could be a myofibroblastic tumor, or it could be a reactive condition, because myofibroblast is a finding seen in healing tissue, right? The second thing which is daring in this image is actually two areas here. Look at this and this part. They have cluttered it with, I'll erase the other marking and becomes much easier for us. This part, this cell, do I have any more thing? Yeah, 2 maximum, fine. Okay, when you look at both these, those are normal, typical mitotic figure. They are not atypical. They are very, very brisk mitosis. I'm having 2 mitoses in half of a 40x field, right? That's something to be worried about. But as I said that when you look at both the mitoses, they don't look atypical, they look normal. It's bipolar mitosis, and it's maybe this might be a metaphase nuclei which is aligned there, right? So I'm having a normal mitotic figure, but a brisk activity. So can this be a reactive bone lesion? It can be, do I have ATPR here? I don't have ATPR. I do have a little bit of a bigger nuclei. Cytoplasm is also more with the myofibroblastic differentiation and typical mitosis but a brisk mitosis. And the first image, if you saw, there was an fibroblastic area, there was an bony area. This is called as a zonation. I'm sure you must have come to some diagnosis here. It's zonation. Differential diagnosis here, or something what we are going to talk about here, is myositis ossificans. It's a very, very classical case of myositis ossificans. So the question should have been, the history should have not been a tibial lesion, must have been a soft tissue lesion surrounding the tibia. That might help you for at some times, right? Again, do you think an imaging will miss myositis ossificans? Might not, right? So the imaging will help me a lot. Plus, sometimes even if the imaging is tough for me, the zonation is an absolute important finding to discuss and diagnose myositis ossificans. Because there are few reactive bone and soft tissue conditions which are very, very close mimicker for malignancy, might be very difficult to pick it up. Nodular fasciitis has lots of mitosis, very brisk. Myositis ossificans, very brisk mitosis. Don't think them as an abnormality. Because whenever there is a very high solid proliferation rate, which is told by mitotic figures, the amount of pleomorphism might also be a bit sometime there. It could be have a mild pleomorphism because dividing tissue, right? So that might skip someone and make them think of an abnormal tissue, but it's not an abnormal tissue, it's just normal. Right? Just have a quick look at myositis ossificans. This is from Foundations of Pathology. It's a very good book if you want to revise. I would say Foundations is not the first book to read to understand concepts. It's always a textbook. It's very good. Foundations just to quick revision. If you're a consultant, if you missed something, if you want to know the salient features, Foundations of Pathology is a very, very good series. Fine. Early lesions, I'm going to have only plump myofibroblastic external shape cells. This is very important. So it becomes, for me to diagnose myositis ossificans, I have to know how a myofibroblastic cell looks. A plump nuclei with lots of pink cytoplasm. And it might be arranged in sheets or fascicles, doesn't matter, intersecting or in lace-like oven bone. That's fine. Okay. High line of fibrocartilage can be present because cartilage, bone, it ossifies, right? Mitotic figures are readily found. It's not rarely, it's readily found. You can easily see them. There were lots of them. To say it is not a malignant process, I should never see necrosis in myositis ossificans. If it's a malignant tissue, the chance of finding a necrosis is a bit higher compared to normal. Right? In a later lesion, when the bone is more mature and well organized, what I'm going to see is my typical zoning phenomenon or zonation. So like we saw in the first image, I had an area full of fibroblastic area. Suddenly it kind of had trabeculae. In between fibroblasts also was present, right? As a typical zonation, a transition from my spindled out myofibroblastic cells. When you look at the high power, they were in the center of the lesion and bone in the periphery. I didn't show you the 4x image, so I cannot say which is center or periphery. But what we were able to identify is a transition from the fibroblastic area to an osteoid area. That's your zoning phenomenon. This is almost like diagnostic of myositis ossificans, right? You keep this in mind, and obviously imaging is going to help me a lot. Why this is more important, we are concentrating on this more is, though in an early stage I won't see them. Early stage, when it's only fibroblastic lesion, let's think about a patient perspective and we'll understand which part is important for me. Myositis ossificans is a finding seen after injury, right? A person breaks the humerus, right? I'm having a myositis ossificans here, in and on the joint. In the joint space, close to the elbow, I'm having a soft tissue lesion. Can I move the hand properly? I can easily move, right? The same soft tissue lesion becomes a bone. Will it inhibit my movement? It will, right? So most of the time, majority of the patients present to the doctor when it's in the bony heart, because when they palpate, they look something wrong. So most of the time, at least in our hospitals, if you take a biopsy, it's going to be in the later stage. So the zonation is very, very important, which can be picked up on imaging also. And extra bone calcification, heterotropic calcification in the bone, and I'm sure the MSK radiologists will have findings to call it myositis, like we do, right? So that's very important for me to understand about myositis ossificans, right? A very brisk mitotic lesion, you shouldn't mistake for something else. And the learning point here is we saw about myofibroblast, right? So what we have seen today is we have seen about 3 cases. I'll just quickly sum up all the 3 cases and we'll finish within a minute. First case was a classical case of fibrous dysplasia. Take home points: curvilinear trabeculae, non-parallel trabeculae, very bland spindle shaped cell, osteoblast trimming will not be present, younger age group. The second thing for me was Parosteal osteosarcoma. It's again more thin trabeculae, parallelly arranged trabeculae, hypocellular fibroblastic area, and you might see mild pleomorphism. Mitosis might be seen mild. At the edge of the lesion, you can see the invasion. So the 2 points which is going to favor me towards Parosteal osteosarcoma is parallelly arranged trabeculae. 1. Loose fibrous stroma. 2nd. If you have any suspicion on a microscopy, or if the imaging has some suspicion of your osteosarcoma, please do MD2 or ANSAT B2, and always look at the marker on a higher power imaging only, not on a low power imaging. That's 2nd. Third one was Myositis ossificans. It's a very mitotically active lesion. You should be able to know how to pick up a myofibroblast. We'll see soon how to pick up a myofibroblast in the Telegram group. Right? Do join the Telegram group, Pathology for Postgraduates. There are lots of students where we can discuss more together. Right? And we have a zonation phenomenon present in Myositis ossificans. Again, imaging will help me. History of fracture might help me as well. Right? So these were the 3 lesions we discussed today. And as I said, that we have lots of lectures going for postgraduates of pathology in the Unacademy app in the form of special classes. All of them are free. Do download the app below, the link given in the video description, and unlock the class using PathoLive or PathoCups, and you can watch them whenever you want and wherever you want. Hopefully we'll read more together. Thank you for your time. See you soon. Till then, bye from Dr. Ranjith. Bye bye.